So out of these two pictures, what are your observations? Can someone tell what they see? You can see two babies. What do you think about the sizes?
The second baby is larger than the first one.
Okay, so which one do you think is the abnormal one?
The first baby is abnormal.
Okay, why?
There is disproportionate sizes of the head and the body.
Okay, good observation. Yeah, so you can either take it both ways, isn't it? You can think the first one is normal and the second one is big, or the second one is small and the first one is normal. As you correctly pointed out, in this instance, the baby that I have put the pointer is a smaller baby, and you correctly pointed out the disproportions of the baby as well. Right, so that brings us to today's topic, that is growth restricted baby. Right, so we are going to talk about who is a small baby, are small babies healthy, what is growth restriction, what is pathogenesis, how do you identify it, what are the causes, some of it which you may have learned for obstetrics also, and what are the complications of growth restriction. Right, so who is a small baby? How do we identify which ones are small? Yes, can anyone give me any ideas on what you all think? How do we identify a small baby?
With a birth weight less than 2.5 kilograms.
Okay, so is it only the birth weight that we should use? You are right. If it is less than 2.5, we call them low birth weight. What about preterm babies? So there are two types, isn't it? There are babies where growth is restricted, or babies can be small because they are born before their dates also. Right? So this word small for gestational age, we'll explain it better. Small for gestational age means babies whose birth weight are less than the 10th centile for age. Right? And so there are two definitions for this. Or baby's birth weight or length less than 2 SD for gestational age. So you can see that is the more recent definition. Why is that more important? Because the current growth charts we are using now do not have SDs, but they have SDs but not centiles. Now the 2 SD line is this line, right? You have learned about growth charts in the growth and development module part as well as the pediatric appointments. So any baby whose birth weight falls, any baby born at term actually, because this chart is meant for term babies, right? Any baby born at term whose birth weight follows is less than this minus 2 SD. So if the birth weight is somewhere here, that baby will be small for gestational age. Any questions with regard to how to check it from the growth chart? Right, so I hope you are aware that preterm babies have a separate growth chart, which I have shown. Again, the pink color one says it's the one for girls. You can see on this side it says weight for age chart for preterm infants. Right, so preterm infants also, again, you can see if you look at this side, right, this is the minus 2 SD line, same coloring. So any baby whose birth weight is less than this. So here on this side in the preterm growth chart, you get the gestation. Because the baby born at 27, 28, 29, and so on and so forth. Right, so in these growth charts, you can see if let's say a baby was born at 35 weeks and the birth weight was 1 kilogram. So it's here. Can someone tell me now, is this baby small for gestational age or not? Yes. So 35 weeks, I'm showing you the chart. 35 weeks, 1 kilo is here. So I'm keeping the pointer here. Is the baby small for gestational age according to this chart? Yes or no?
Yes.
Yes. Okay. Let's take another example. Let's say a 28-week baby. So we are here, right? And for 28 weeks, baby is born at 1 kilograms. Now, still the weight is the same, but baby was born earlier at 28 weeks. Now, is this baby small for gestational age or not?
No.
No, right? It's not, because the gestation is different. So 1 kilogram is okay for, or it's big for a 28-week baby. But it's not enough for a 35-week baby, because we know while the baby is in utero, baby matures and will grow on to say something more than 2.5 kilograms, around 2.83 kilograms weight before it's born. So whether it is gestational, whether it is small or not will depend on the gestational age as well. Does anyone need any clarifications with regard to plotting it in the growth chart and deciding, identifying whether someone is small for gestational age or not? Yes, because you are expected to do this. I hope it's clear to you if you have no questions, right? Okay. So, you can see in this chart, right? So, those below the 10th centile or below the minus 2 SD are the small for gestational age babies. Those between the 10th and 90th centiles or between plus and minus 2 SD are the appropriate for gestational age. Those above the 90th centile or above the plus 2 SD are called the large for gestational age babies, which we frequently see in mothers with diabetes, right? Okay, and these different colors are there, as your colleague pointed out at the beginning of the lecture. Any baby weighing less than 2,500 grams is called low birth weight. Any baby weighing between 1,000 to 1,500 grams is called very low birth weight. Any baby weighing less than 1,000 grams is called extremely low birth weight baby. Right? Okay, so the next question. Are small babies healthy? So what do you think? 40% of small for gestational age are healthy. 90% have chromosomal abnormalities. 50% are growth restricted. So I am not expecting you to know the answers, but you can take a guess. Yes? What about the first statement? Do you think there are healthy babies among small for gestational age babies, or do you think everyone has a problem?
Some are healthy.
Some are healthy. Okay. What about the second statement? Do you think 90% of them have chromosomal abnormalities? I'm sure you have come across small babies during your pediatric and maybe obstetric appointments also. So did most of them have chromosomal abnormalities?
No, madam.
So that statement is unlikely to be true. Then again comes 50% of small for gestational age are growth restricted. What do you think about that? Any comments? Okay, so let's move on and see. So how do we classify these small babies? Right, so small fetuses based on clinical evaluation and ultrasonography are divided into healthy small for gestational age babies, right? Or they are also called constitutionally small. The other group is true IUGR or pathologically growth restricted. So there is a group that is healthy, right? Healthy small for gestational age or constitutional small. These guys are small maybe because their parents are small, but nothing is wrong with them. Then there is a group of children that growth is restricted. So you call them the pathological growth restriction. Out of them, there are two types. There is the type 1 where there is symmetrical IUGR, which is also called intrinsic growth restriction, where head, chest, everything is proportionate or proportionate growth restriction. And there is the asymmetric growth restriction or what is called the extrinsic IUGR. So we talked about percentages earlier. So out of all the small babies, right, all the small for gestational age babies, 20% are healthy. 40% are growth restricted. So that is the extrinsic growth restriction they are talking about. And 40% are intrinsically growth restricted. Right? So out of all the small for gestational age babies, 20% are healthy. Whereas equal proportions are divided among which parts are intrinsically growth restricted and which part is extrinsically growth restricted. So what is growth restriction? IUGR stands for intrauterine growth restriction. The more recent term is fetal growth restriction, FGR. So this means the infant has not reached its growth potential. So babies that could have been larger if not for some interference, maybe environmental, maybe genetic, whatever, something has affected the growth. Right, so now we are going to talk more about the pathogenesis and the types of IUGR. Right, so insulin limiting fetal growth can happen, insults limiting the fetal growth can happen during early gestation as well as during the latter part. If it happens during early gestation, there is global reduction in the fetal growth. Right, which means it will cause symmetrical growth restriction. It will affect all the tissues the same. So everything will be small. If it happens in the latter part of the gestation, it will affect specific tissues because different tissues will have different growth rates towards the latter part, and there will be a head sparing effect. That is what you saw and what your colleague correctly mentioned in the first picture. Right? So head sparing effect where the head will look big and the body will look small for a while. So, fetal growth, there will be different phases. Hyperplasia, now you have learned these terms during your foundation or during your first year or second year. Can someone tell me what is the difference between hyperplasia and hypertrophy?
Hyperplasia is increasing the cell numbers. Hypertrophy is increasing the cell size.
Excellent. Okay. So, the first few weeks, or let's say now, first trimester, it's a little more than the first trimester, between the first period, between 0 to 16 weeks, or say, let's say, predominantly first trimester, growth happens due to cell hyperplasia. Whereas during mostly the second trimester and a little bit more, 17 to 32 weeks, it occurs due to both cell hypertrophy as well as hyperplasia. Whereas in the latter part, after 32 weeks, it is mainly due to cell hypertrophy. So this might explain as to why an early insult will result in a global reduction or a symmetrical growth restriction, whereas a later insult will result in asymmetrical growth restriction. Okay. Now here we are going into the effects, the causes and effects of growth restriction. So if we consider it broadly, either abnormal placenta and abnormal uterine blood flow. So reduce something to do with the placentation and altered uterine blood flow will impair fetal nutrition. On the other hand, maternal undernutrition or malnutrition will also impair fetal nutrition. And impaired fetal nutrition will result in intrauterine growth restriction as well as a difference in organ growth and maturation. And this will in turn have effects on different organs in different ways. So in the kidney, it will reduce the number of nephrons. In the heart, it will reduce the number of cardiomyocytes. In blood vessels, it will affect the endothelial function. And in the pancreas, it may result in reduced insulin secretion. And the hypothalamo-pituitary axis may show alterations. So all these may result in programming of cardiovascular disease in adulthood. Right? We will talk about all this in a little while in detail. Does anyone have any? This is a bit of a complicated picture, but it kind of summarizes everything we are going to talk about. Right? It tells us how and why growth restriction takes place, what effects happen because of growth restriction, and how it can affect adulthood as well. Does anyone have any questions with regard to this diagram? Okay. So moving on to another diagram. So when there is alteration of the blood flow to the fetus, and when the fetus is not getting enough oxygen, our body tries to preserve the vital organs. So the vital organs identified by the body are things that are needed to keep us alive. So the brain, heart, and the adrenal. So what happens is if the fetus gets a problem with the blood flow or the blood flow is limited, the body will try to redistribute this blood flow to the heart, brain, and adrenal at the expense of other organs. Right? So the heart and brain they will try to preserve the blood flow to those by diverting blood from, let's say, the kidneys, the gastrointestinal tract, the bone marrow, so all those other things that are not considered essential for life. Right? So that is the meaning of distribution of blood flow in hypoxia. So what the body tries to do is it tries to preserve the heart and the brain till the end. So if the heart or the brain has got hypoxic, that means that obviously all the other organs have already got hypoxic. So this becomes a factor in diagnosing hypoxic ischemic encephalopathy, or what was known as birth asphyxia, I think, which is another area we are going to discuss at a later lecture. Okay, so we talked about how growth restriction is classified, right? So symmetric, which is sometimes called type 1, accounts for 20% of the growth restriction. Here the percentages are a little different, where the onset is early on in utero. And asymmetric type, which is 80%, happens later. So the symmetric type, what is responsible is congenital infections as well as genetic disorders. And the pathophysiology, as we discussed earlier, is impaired cell division, decreased cell number, which will result in decreased cell number, and it's an irreversible insult. So this will cause inadequate growth of head and body, where the ratios may be normal, but the prognosis is poor. So this is a group of children who will have chromosomal abnormalities and those who will have congenital infections like the torch infections, right? So Toxoplasma rubella, that group. Then the rest are, so the majority could be where there is uteroplacental insufficiency or due to maternal malnutrition, hypertension, whatever. It's more due to the nutritional issues of the fetus or the placenta. Just a minute. Right, sorry about that. So, asymmetric growth restriction is mostly due to uteroplacental insufficiency or the maternal nutrition issues, right? And that happens because of impairment of cellular hypertrophy and decreased cell size, and it can be reversible. So what it means is, why do we say it's reversible? If the baby is taken out of that particular environment, the baby can resume its growth according to its genetic potential. Whereas in the symmetric or type 1 type, something is wrong with the baby. So whether or not it is in whatever environment it is, things are not going to change. Right? So if the baby is infected with a congenital infection or there is some genetic abnormality in the baby, wherever the baby is, the uterine environment or the maternal nutrition is not going to change things. But if it is the maternal nutrition or the uterine environment which is restricting the baby's growth, once the baby is taken out of it, the baby can resume its growth. Okay. Right, so therefore, in this group, this is the kind of babies who will be identified and may be delivered earlier before they mature into term by the obstetric team. So in order to preserve their growth. So in this second group, brain is spared and therefore the head to abdomen ratio is increased and they have a more favorable prognosis. So what is the type of growth restriction in this baby?
Type 1 restriction.
Is it? Doesn't the head look a little bigger than the rest? Type 1 restriction, or it's a symmetrical one, I would expect the head to be smaller. I would think this is more like a type 2 because the head seems a bit big compared to the rest of the body. Okay. So how do you identify fetal growth restriction? Right? So one thing is another question. What is the factor other than growth parameter that is needed to diagnose growth restriction? Anyone? It's a gestational age, right? We need the gestational age. Without it, that's what I showed you in a previous example. I showed you a 1 kilogram baby who is 28 weeks, which is appropriate for gestational age. But if it is 1 kilogram at 35 weeks, that is growth restricted or small for gestational age. So accurate timing is essential for us to see whether the baby is growth restricted or not. So which means a dating scan is needed. Right, so it is standard care in our country to provide dating scans for all babies, all mothers, right? So I think it's important sort of that to make sure it's done, and we need to check what the dates are according to the dating scan. Okay, I just have a question from Mr. Damita. There is a thing saying that the meeting is going to end in 7 minutes. Do I need to do anything about that?
Yes, madam. There is a limit in Zoom for 40 minutes, so you have to press the link again and connect. Nothing else.
All right. Same for the students, no?
Yes, yes, madam.
Okay. Thank you. Right. Okay. So if the meeting ends, it says 7 minutes, right? Please press on the link again and join again. Right. So other than for the growth factor, what we need is we need the gestational age. And how do we get the gestational age? It's because every woman should have a dating scan between 8 and 13 weeks. And with this, accurate timing will be obtained. Right. So how do we screen for the fetal growth restriction? Right, symphysiofundal height is checked in every lady that comes for the, every pregnant lady that comes to the antenatal clinic. And it is expected to be equal to the weeks of gestation after 20 weeks. But as you can see, sensitivity is 60 to 80% and specificity is 80 to 90%. So it's not foolproof. It's not 100%, but it's a good screening. So how do we confirm growth restriction? Yes, can someone tell me how do we confirm growth restriction? So we screen by checking the symphysiofundal height. How do we confirm? If we feel the symphysiofundal height is not equal to the gestation of the lady, which we have found from the dating scan.
So in that case, then you'll have to do another ultrasound. So not your routine mid-T scan or your dating scan. You do another ultrasound scan and you have these parameters like head circumference, femur length and all of those.
Yeah, very good. Okay. So we can use the ultrasound to confirm the fetal growth restriction. So then again, as your colleague mentioned, at different times, there will be different measurements that are more sensitive. So the most sensitive indicator of fetal size has been found to be the abdominal circumference, right? Reduced lipo volume has also been found in 30% of the women. So why that is used is, the basis behind it is redirection of blood flow. We talked about redirection in case of hypoxia, and in that case what would happen is, we said the kidneys, the blood flow will be redirected from the gastrointestinal tract and the kidneys to the heart and the brain. So this would cause reduced blood flow to the kidneys, resulting in reduced urine output, which is which sort of contributes quite a lot to the lipo volume. So in turn, if the urine output is reduced, it will result in a reduced amount of lipo, right? So the Doppler ultrasound is what is used to check the flows, right? This can be used to check the blood flow to the placenta. It is used to detect poor placental function as well as increased placental resistance. So what is checked is pulsatility of the umbilical artery as well as increased placental resistance will entails increased pulsatility of the umbilical artery as well as reduced pulsatility in the cerebral arteries. So you may have already done this, or if not, you would be doing this, right? So in a normal pregnancy, you can see there is a, we get the laser pointer, right? There is some width from the baseline, right? And there's nothing going down. But if in reduced end diastolic velocity, you can see the height, the blood flow during diastole has reduced. So you can see a reduced height from the baseline. Absent end diastolic blood flow, you see blood flow only during systole, no blood flow during the diastole. And reverse diastolic blood flow, you can see the blood flow is reversed during diastole, right? So this is an important finding which helps in the management, which helps the obstetrician to see what is happening with the blood flow. And if you remember, we said, so these babies, because the environmental conditions are poor, are having growth restriction, right? And if you take them out of the environment, basically that means if you deliver them, take them out, this problem will cease. If you don't do it, what will happen is, there is a limit that the body can cope up. The brain and the heart will get ischemic. Either the baby will die or the baby will have very poor neurodevelopmental outcome. So it's very important that the baby is delivered before it, gets into this reverse diastolic velocity sort of poor blood flow pattern. Right. So this is a real life picture. Whereas the previous slide, yeah.
Excuse me, madam, what happens in reverse diastolic state?
Meaning?
In that absent state, there is no blood flow. So reverse means?
I think it may be flowing the other way. Sorry, don't know really.
Okay.
Okay, you will get this lecture in obstetrics. You can ask them.
Okay.
I haven't really gone into that level. Sorry about that.
Okay, ma'am. Thank you.
Okay? Yeah, all I know is that it's very bad that you need to deliver the baby very soon. Okay. So, but actually with the reverse blood flow, it means there is no blood flow to the cerebral arteries. That's what it means. But how does it happen and how to explain the picture, I'm not sure. Right? So again, these are the real life pictures where you can see, hopefully you can see the same thing. You can see a height of diastolic blood flow. It is reduced in the reduced blood flow, which is the second, this line. And then you get the absent end diastolic blood flow. And then the last one, you can see the reversed one. Okay. So this is what I was getting to. So because I'm usually at the other end, when they helping with the planning of delivery, when there are issues with the blood flow, so the obstetric team talks to us with regard to whether we should deliver the baby or not. Because let's say the baby is 20 weeks or something, there is no chance of survival because the baby has not grown at all. So in that situation, we have to look at whether the baby will survive if the baby is taken out, also with regard to gestation. Right? So that is why they talk with us with regard to that. So if we look at this, the umbilical artery blood flow and will be taken.
Yeah, it was this slide.
Right, okay. Few more joining, I think. Okay, I think most have joined, right? So, so once the baby is found or once fetal growth restriction has been identified by screening, ultrasound scan will be done and then regular Dopplers will be done. So if the Doppler is normal, they will decide to deliver at term, right? If the Doppler is normal and if there is oligohydramnios, right, they will do other tests and deliver if those are normal, the biophysical profile. If the Doppler shows reversed end diastolic flow, that means that there is reduced blood flow to the brain. So that means the baby should be delivered immediately. Right? If there is absent end diastolic flow and there is oligohydramnios, the baby should be delivered soon or immediately. And if there is absent end diastolic flow and if the baby is more than 33 weeks, again the baby should be delivered as soon as possible. If the baby is less than 33 weeks, that's all there is in that. Then they have to discuss with the pediatric team. So actually we are okay with babies more than 26 weeks, right? So this chart has been, different places will be comfortable with different levels of neonatal care. But the baby has a good chance of surviving. Definitely more than 28 weeks, an excellent chance of survival. 26 to 28 again. The thing is, if prematurity is one insult, but having a growth restricted baby with preterm, your chances are very, very poor. So rather than having a very growth restricted baby who is preterm, who is sure to die or sure to have very bad prognosis, we would prefer the obstetric team to deliver a baby, let's say, who is more than 26 weeks or more. 24 to 26, you have to take your chances, counsel the parents that the prognosis is bad either way. Right? Because we are comfortable with looking after like viability or the period of gestation beyond which the babies would live is 24 weeks. Right? But 24 weeks means again pretty early, almost halfway through the pregnancy. So 24 to 26, there is a chance of maybe 50-60% survival. But after that, 26 to 28, it's more. After 28, if there is nothing else wrong, the baby should survive. So more than 90% survival. So taking all those into account only, delivery should be planned when the baby is preterm. Right. So now we come to
Madam, in the previous slide,
here it said that if it's more than 33 weeks, we deliver.
I think there's something wrong with that. No, this should be less than 33, which I have also taken from somewhere else.
Okay, thank you. So, madam, if it's less than 33 weeks?
Yeah, if it's less than 33 weeks, there should be a discussion, because that means now two problems. No, one is the baby is getting growth restricted and the blood flows are getting worse. All right, I mean there's no end-diastolic blood flow, which means the baby is getting hypoxic, already hypoxic to a certain amount. Second problem is, so that is one issue, taking the baby out. But by taking the baby out, if the baby is very preterm, that is what I said. Because prematurity also, like say if the baby is 20 weeks, baby is not going to survive anyway, no? We cannot support a baby who is 20 weeks. Do you understand the problem? So yes, make a more and on it, right? I think maybe the sign is wrong or whatever. I didn't want to go into a lot of detail about this, because this is actually the obstetric team will teach you this. Right? This is the basis as to why these scans are important and why we talk about end-diastolic blood flow. So from the pediatric point of view or the neonatal point of view, my team should find out whether this baby has had Dopplers and whether it is what sort of Dopplers the baby is having. Because if we get a referral from the obstetric team, if the Dopplers are absent, I would be more towards delivering that baby, because having hypoxia plus preterm, if it is more than 33, 34 weeks, then that is absolutely fine. The problems of prematurity are minimal. But the more preterm it gets, say, that's why I said, if it's more than 28 weeks, we are very comfortable. Those babies generally have no problem at all. If they don't have any other issues, like, infection or congenital abnormality or some other problem. Between 26 to 28, again, not as good as 28, but maybe 70-80% of them will survive. Between 24 to 26 is tricky, because anyway, lots of problems on prematurity if they are born around 24 weeks. So then the chances of survival are anyway about 50-60%. Less than 24, there's no chance of surviving. Because of the prematurity, they will die anyway. Do you understand the problem? So even though you are getting hypoxic inside, even though by delivery nothing much may be done. So then maybe you have to sit and counsel the parents, talk to them about the outcomes, prognosis, and then take a joint decision. Because if the baby is going to die anyway by delivering very early, say 22 weeks, 23 weeks, then there is no point in delivering. There is no point in trying to do a section and trying to deliver the baby early if the prognosis is anyway poor. So I just wanted you to get an idea of how growth restriction may impact delivery, right? Not to take specifics away from this. What our obstetric team does, this 33 weeks cutoff may be different, but the obstetric team is doing. So that part you should pay attention to what they say. But what I wanted to show you is how this pathogenesis of, this redistribution of the blood flow and this diastolic flows, how they impact on the decision to deliver. And this might be the reason for some of the preterm deliveries that have occurred. The reason for delivering a baby preterm is because they are growth restricted. And because if you keep them further inside the in utero environment, they may get hypoxic and have brain damage. So then taking the risk of prematurity, you deliver them anyway. Did I answer that question?
Yes, madam. Thank you.
Okay, so moving on to causes for growth small for gestation. Right? So there are fetal factors, maternal factors. So these we are leaving out the constitutionally small babies, right? So among them comes the constitutional ones who will have no issues, which means the family is small and therefore they are small. But there are also chromosomal problems like Down syndrome, Edwards, all those things will cause growth restriction. There can be malformations, infections, and also if there are multiple pregnancies, each fetus becomes smaller because there will be limited space in the uterus. So constitutionally small babies, they are anatomically small, they have normal Leica volume, they have normal Dopplers, they will have a good outcome, right? So that's the normal group of babies we talked about earlier. If you take the chromosomal abnormalities. So can someone tell me what this chromosomal abnormality is?
Trisomy 21, so down.
Very good. Okay. So, and you can see some of the facial features also here, and you can also see the karyotype given here. Right. What about this?
Edwards syndrome.
Yes. You can also see, if you remember, the baby is hypertonic, fisting is there, the 2/5 anomaly. Right, rock-bottom feet, of course, not very clear. So this is exactly what Edwards syndrome child will look like, and that's the karyotype. So these babies are expected to be intrinsically small. So then again, that's not a real-life picture, but that's a picture of Patau syndrome, trisomy 13, where you get lots of midline abnormalities. So intrinsically small fetus, right? Even from the obstetric point of view, if you see that most of the time now they do intrauterine genetic testing actually before it comes to us, and some of them come with the karyotypes which are already done. So they test for chromosomal abnormalities as well as for congenital infections. Right. So moving on to malformations. Right. Okay. So there can be different malformations seen in babies. I can't figure out what that is. Okay. If you go to this, coarctation of aorta is one. Then you can see, so different congenital heart disease, right? ASD, this is to just remind you what you have maybe done already in the cardiovascular module under congenital heart disease, where there are left to right shunts, can be that. There can be VSDs, right? What is this? So that's it for the cardiovascular issues. What do you see here? What do you call this condition?
Anencephaly.
That's right. So anencephaly, right? The scalp or the head skull part is not grown. This one? This is the opposite. The huge head. What is this?
Macrocephaly.
Yeah, macrocephaly means large head. Can you be a little more specific?
Hydrocephalus.
Yes, hydrocephalus means there is, maybe there is a block in the ventricular system somewhere, and there is increased intracranial pressure due to blockage of CSF. You can see a lot of classic signs here. You can see the dilated veins in the head. You can see the sun setting sign, right? So anyhow, this would be another reason why the baby is growth restricted. And this one?
Spina bifida.
Yeah, or it is a type of spina bifida, more specifically meningomyelocele. No? Meningomyelocele. It looks more like a meningomyelocele with spinal cord also out. If you see a baby like this, if you are given to ask one question from the mother about her supplements, what would you ask? As a cause, to find out the cause for this?
Folic acid.
That's right. Whether folic acid during what period?
Preconception.
That's right, right? Because generally everyone, once they know they are pregnant, will take the folic acid, but this happens if you don't take the preconceptional one, because during the initial part, the folic acid should be there. Okay. This one? This is ectropia vesicae, where the bladder is out, right? And here you see pictures of renal anomalies, where there is bilateral PUJ, pelviureteric junction obstruction, hydronephrosis, hydroureters, posterior ureteral valves. So all of these. What is this?
Gastroschisis.
That's right. So the intestines are out. Okay. And this X-ray? Focus on the upper part. That's also a gastrointestinal abnormality. So, why we went through all those pictures are to understand that we saw that one reason. Say fetal factors, important ones would be chromosomal abnormalities and various malformations. Then there can be maternal factors, genetic, constitutional, chronic illness, drugs, and uterine abnormalities. So how do the maternal factors cause fetal growth restriction? So there are certain things which will affect the placental growth. Age, altitude, infections, preeclampsia, smoking, undernutrition, all these can result in placental insufficiency, which will in turn result with reduced nutrient transport and resulting growth restriction of the baby. Right. Then there are also socio-economic factors like social deprivation, alcoholism, smoking, drug abuses, street drugs, and poor diet can also cause to undernutrition of the mother as well as poor growth restriction in the baby. Right. So those are some of the causes that cause restriction of growth. Then what are the complications, right? There are different complications which occur at different times. Some occur during the delivery itself, intrapartum, during neonatal period. Right, so this is again to remind you of the various things that happen so that it will help us to understand the complications. Then again, this we saw earlier, this is to remind you that this is a baby who has got hypoxia. So there will be problems with hypoxia. So intrapartum, the baby can get hypoxic. And result of hypoxia is when you switch into anaerobic metabolism and which results in lactic acidosis. Hence the acidosis. When there is hypoxia, the anal sphincter will open and that will result in meconium getting into the ligum. If the hypoxia continues, baby's respiratory center will shut down and the spinal center for gasping will be activated and baby will gasp in or aspirate the meconium, causing what is called meconium aspiration syndrome. If the baby is very hypoxic, that may lead to the death of the baby. So if there is no signs of life at the time of birth, we call it a stillbirth. Then the neonatal complications. So if the baby is born, there can be issues with hypoxia. If the baby makes it, right, there can be what is called hypoxic ischemic encephalopathy, where you get multi-organ dysfunction. Baby may get fits, coma, various things. Then low Apgar's pose and poor condition at birth. Then there is a condition called necrotizing enterocolitis. This is where the gastrointestinal tract intestines have been ischemic and they will show inflammation and reaction when once there is no more hypoxia. So babies who are growth restricted and who have had bad Dopplers with say absent or reversed end-diastolic flow are at high risk for this condition called necrotizing enterocolitis. So breastfeeding is protective in this situation. Again, coagulopathy. Reason being, we said blood flow is redistributed, which means these babies can have, say, renal failure, liver failure, coagulopathy, necrotizing enterocolitis, all the other organ systems are likely to fail depending on the degree of hypoxia. Then there are some issues because they are small. Because they are small compared to the volume is small compared to the surface area, they are more prone to get hypothermic. Then their reserves of glycogen are low, therefore they are more prone to get hypoglycemia. Because of the hypoxia, the erythropoietin response will be higher and that will lead to polycythemia. Again, because they are small and maybe they will need more intervention, so they will have higher risk of infection. If they are born preterm, their immunity will also be less, which will also increase their risk of infection. Again, feeding problems are higher because they get tired with feeding. They may not be able to suckle for as strongly or as long as a baby who is not growth restricted. So they will need extra support with feeding. So when we are managing a growth small baby, we need to look at temperature control, screen for hypoglycemia, look out for infection, right? Support feeding. So we may need to give express breast milk via cup feeds. Okay. If less than 2 kilograms and in addition to direct breastfeeds. Right, so that is supporting a small baby for breastfeeding, giving skin-to-skin care. Right, that is a picture showing cup feeds. Right, now what happens to these babies? So what you can see here is the smaller the baby is, the more growth restricted the baby is, higher the morbidity as well as the mortality. Right, so what are the problems with long-term morbidity? These babies can have developmental problems. Why? Because there is a risk that they have already become hypoxic. This is why it's important to decide whether we can deliver these babies before there are effects on the brain. Right? Otherwise, if the effects have occurred, we cannot reverse the effects that have already occurred. So because of that, if these babies there is a risk of cerebral palsy, as well as various other issues with fine motor, social skills, as well as school performance. So we can avoid all this if we pay maybe close attention to the stuff, but also if there are intrinsic problems, it will contribute to this as well. Then there is something that is called the Barker's hypothesis, which I wanted to introduce, right? I think it's something that is worthwhile for you to know. So Barker in the 1990s proposed this hypothesis where he studied men and women, 100,000 men and women who died due to coronary artery disease. And what was found was that their birth weight was inversely correlated with increased early death with coronary artery disease. So this brought about Barker's hypothesis, which found that if the babies are growth restricted or born with low birth weight, they have undernutrition in utero, which we were talking about, and they can have disproportionate fetal growth, and that can lead to cardiovascular disease. So this is also what is called the developmental origin of adult disease. Right? This has been thought to explain the higher incidence of non-communicable disease, right, in adults who are growth restricted. I mean, there are other things that come into this hypothesis as well, right? So, low birth weight or growth restricted babies have a higher likelihood of developing hypertension, coronary artery disease, dyslipidemia, as well as type 2 diabetes. So again, this is another study which shows that the smaller the baby, the higher risk of neonatal death, metabolic syndrome. You can see the risk ratio of neonatal death is higher. APGAR scores are lower. The mortality is higher. So there are many things that can go wrong with these babies. Okay, so that's to the end. Any questions?
Excuse me, madam. Can appropriate for gestational age also be considered as IUGR in certain conditions because it's based on genetic potential?
IUGR, no. You can't say the IUGR. But what do you mean? Because when we say it's appropriate for gestational age, we are looking at a specific gestational age and saying that their birth weights are between, plus or minus 2 SD. So you can't really say they are growth restricted in that sense.
Okay, thank you.
Are you saying comparing to their parents? Is that what you're saying?
Yes.
Well, I mean, they can, let's say, there is no term for that really, but maybe let's say this guy becomes short or something. Then that's one of the times we look at the mid-parental height to compare. So in that sense, there can be a growth issue can be there, but you won't call it a growth restriction. No, you will call it something else, I guess, because this is growth restriction. Fetal growth restriction is basically based on, your growth parameters. So whatever the obstetrician measures during the pregnancy as well as what we measure at the time of birth. So the term IUGR will not come there, but there can be problems related to growth. That is correct. Even growth appropriate for growth age babies can have growth disorders. Does that
Okay,
answer?
thank you. Yes, madam. Thank you.
Anyone else? Okay, so that's a picture of a 650-gram baby born at 26 weeks. Right? Well, she's quite good. She's neurodevelopmentally well. She was exclusively breastfed. She had lots of issues, was in the hospital for maybe 3-4 months until she regained her, decent birth weight to send home. Okay then, if you have no more questions, we can finish up for today. You can ask me if you have questions even later when I join you for some other stuff, I guess. Okay, so thank you for being an interesting audience. You asked questions. I enjoyed it. I hope you keep it up. Thank you.